I wanted to share something with you before I start my next talk. And this comes from somebody that we all know. Her name is Agatha Christie. So this is something that Agatha Christie said, and I was really keen to share this before lunch, but I got a bit distracted. An archaeologist is the best husband a woman can have. The older she gets, the more interested in her he is. So there we are. I will have to share that with my wife, but I'm not sure when. What we're going to talk about now, the next bit, is we're going to talk a bit about wound infection, biofilms, and very briefly brush what we're doing with antimicrobial agents. I can see that based on our conference today, there are subjects that are coming up that each of them need their more intensive investigation and discussion. So having spoken to Linda and team, I think keep an eye out because we need to be doing a series of workshops to cover some of today's content in more detail. And this is a subject which lends itself well to that very workshop idea. Now, the Medical Journal of Australia did some statistics in 2015 and said that the number of people in 2015 who had a surgical site infection was 21,000. Now in hospitals, surgical site infections are reportable. So last year, 21,000 people did share their notification or had their details shared about having a surgical site infection. They also said in the Medical Journal of Australia that about 6% of hospitalised patients acquire an infection, with many more patients with infections reporting to their GP after early discharge. Some of the most common infections include catheter-related UTIs, intravenous cannulas, and surgical site infections. Now, we're talking about wound infection, biofilms, and antimicrobials. And when we do talk about these subjects, at some point we will talk about the term debridement. What is interesting is Villers de L'Isle Adam, back in the 1700s, made this comment. He said there are some wounds that one can only heal by deepening them and making them worse. Now that of course was written in French, that's just the English translation, but he was of course talking about the word debridement. And you heard me mention before about us as nurses doing debridement and how now with things like ulcer cleaning systems and debris soft and some of the antimicrobials that we will mention, we do now have some of the tools available to us that we can be doing these things. But I would like you to see where all of this fits into the scheme of wound infection and biofilms. So let's start. Okay, now there is a gentleman's abdomen, where down here is his groin, there is the weight of his rather pendulous abdomen. I'm not sure because my friend Steve, who sent me this picture, didn't tell me what actual kind of operative procedure this guy had had, other than the fact that here we have a wound now dehiscing and breaking down, and you can see all of the redness and swelling that's associated with that. And there is, you can see just a little bits of reflective plasma. There's a lot of exudate associated with that, and a fair bit of whiff as well. So definitely that's something that we might look at and say, yeah, we think that probably is an infection there. Let's carry on because there's more things to share with you. There is on this slide and the next one, they do tend to like to put up risk factors of who is most susceptible to getting infections. And the one that comes out from this is that certainly the very young and the very old, by way of the changes that are their immune system response, are susceptible. And certainly anyone with an indwelling device will find that, again, the nature of their inflammatory immune system response will have some compromisation. Back in the mid-90s, it was seen to be as moderately alarming that health workers should have MRSA nasal colonisation. And now that we've moved on about 20 years, it's more kind of unusual when a health worker doesn't have MRSA nasal colonisation. It seems that this is one of the things that may have become a bit more of the norm, not to say that it's acceptable, but certainly more common. These are certainly risk factors that make people, if they do get infections, a bit harder to identify that the infection is even there, and if it is there, then harder to eradicate. And we mentioned earlier the whole bit with the folks who are diabetic. People who've got diabetic changes and their vascular supply is altered as a result, their immune system and white blood cell function changes significantly. And so many people with diabetes do not have a normal response to infection, and you may not see all of the signs of infection there should they have a wound. You may not always see the redness. You may not always end up seeing the edema or the warmth. Sometimes it may only be a change in pain, if there is any pain, or it may just be the fact that the wound is getting bigger or becoming more voluminous in the amount of exudate. Sometimes they might be the only changes. But as you go through that list, each and every one of those may have some aberration in the way that they might show up, all of the signs of infection, and then demonstrate their ability to deal with it. They reckon that by 2030, 10% of the worldwide population will have diabetes. So if you want to put that into context, that means you've got Australia, New Zealand, Papua New Guinea, Indonesia, and most of the South Pacific, all with diabetes. Isn't that amazing? No wonder it's something we need to start urgently dealing with right now. Historically, this was a formula that I was taught, maybe you were as well, but it gave us a bit of an insight as to what might happen when somebody had to deal with colonisation or infection in their wound. They look at saying, well, the ability of your wound to get an infection might be dependent upon the number of bugs that there are, how aggressive those bugs might be, but this is the part of the formula that we've often never really spent a lot of time talking about. We talk about what the bugs might be, we might talk about how aggressive they are, we might mention as to what kind of numbers the swab result says that they're there in the wound, but one of the greatest abilities to combat infection is how well our patients are themselves. And sometimes some of the best wound care and some of the best infection control is all about our residents being well watered so that they have adequate hydration and that they have adequate nutrition, that they have access to good hand washing practices with their own environment, and the ability to get rid of waste products like dirty dressings and disposables and indwelling devices, that all of these things can be removed and gotten rid of properly, including sharps and so on. So how we can prepare our patients' homes and environments, the carers that might be associated with them and affiliated with them, how we can build up that person's own well-being, all of these are important aspects of controlling infection and the resistance to infection. But let's now get angry and spend a little bit of time talking about biofilms, because what are they, this trendy new way of thinking about infection? So let's spend a bit of time trying to make that make a little bit of sense. The definition is something that is okay to read, but I just want to show you a little bit of that definition, where it talks about the fact that we have a community of bugs in a wound. And they use the word here, interdependent community. And what happens is these bugs are present in a wound, and these bugs are protecting themselves with what we call a polymeric matrix. In other words, it's a very tough coating that normally antibiotics don't get through, that normally cleansing agents don't get through, and so these bacteria are living very happily all together in an isolated cage of a community, staying there within a wound bed, slowly reproducing and shedding off parts of itself to keep a wound perpetually inflamed. As we've learnt more about these kind of bugs, we realise that most open wounds and probably all chronic wounds, non-healing open wounds, will probably have a biofilm on them. Now, is that going to be enough to stall healing? If the host, the resident, the patient, if they don't have adequate host resistance to infection, then the answer is that for many of them, an open wound with a long-term biofilm community might be all that's required to keep their wound from healing. So there is work going on as to say, well, do biofilms actually stop wounds healing? Or do biofilms, are they present in wounds that have already themselves stopped healing? And what is the relationship between some of these factors of a person's well-being and their comorbidities? So there is certainly a lot more we need to find out about. But let's look at a few things. Please ignore John Howard on the far right for you there, but that caricature did pop up. I'm not sure he's particularly got a lot to do with today's presentation, other than there is a moist surface, often open, and perhaps resembling something of a chronic wound or depository. Biofilms and bacteria like environments which are damp. And this is one of the things that when Matt was talking before about the black wound, which is very dry, it might be the unstageable pressure wound, but it's a complete covering of black eschar or material on a wound surface which is bone dry. It is worthwhile leaving that kind of tissue on a wound because the dryness of it, the density of it, tends to resist the growth of biofilms because these communities of bacteria like it to be wet. So that's the first thing. The surface to which a biofilm will attach must be associated with moisture. Biofilms often do start to develop within minutes, but they become certainly more established within hours, and usually within a few days they are a mature entity able to resist antibiotics and many antimicrobial agents. And so the older the biofilm becomes, the more resistance there is to us being able to do anything really about them. The other clever thing about this community is the community shares information within itself. It's what they call quorum sensing, where it can share pieces of genetic information, can share pieces of cellular information, and so it is that a biofilm learns to organise itself so that it can look after its own well-being and longevity. So bugs that don't like the presence of oxygen will organise themselves so that they're down deeper in the wound. The bugs, which are very happy in the presence of oxygen, will live on top of those anaerobes, and they will eat up all of the oxygen, which makes the ones underneath very happy, and thank you for doing that, lads, that was awesome. In with these bacteria is also a community which might involve funguses and viruses and other ingredients as well, which are all part of a host looking after a farmyard of other animals. So quite incredible what can learn to coexist, and then they cover themselves with this protective layer. When we look at what a biofilm is, isn't it interesting that biofilms are mostly water, which is again why in a dehydrated wound or a dry wound, we don't tend to have troubles with biofilms. They need a moist environment. And this is now very apparent when we can see that mostly biofilms are a lot of water. They also are made up of a lot of sugars and proteins, and this is where they get their energy from. Whereas the actual bugs themselves make up about 20% or less of the community itself. So the community is bugs with their support structures, with plenty of water, plenty of tucker, and I can live here indefinitely. Thank you very much. This is a sequence that goes through the stages of what happens for a biofilm to develop. It finds its wet surface, it gets stuck onto it, it then starts to secrete all of these sugars and proteins as the energy source. When that's happening, you then might have other bacteria or other viruses that say, hey, that's a pretty good environment, I think I might join that, I like that. They come on board, the community becomes stable, and hemostatically regulated, which means it's talking to itself, it's layering itself, it's saying, you go here, you go there, I'll do this, you do that. And then these entrenched microbes become senescent. Now, we mentioned earlier today how lipodermatosclerosis is good for Scrabble. Well, so is that word, senescent. And it's the kind of thing that you can just drop it into a conversation and you can look so intelligent and no one around you is going to know what the heck you're talking about. Senescent cells are cells which have not died. They have just gone to sleep, basically. So what happens is you've got bugs which are lying deep in the wound, which haven't died, but they have gone to sleep. And they will stay that way until such time as there is a break or damage to the biofilm and they need to remake it all over again. Then those sleeping cells become awake and active once more. They remake their community, and when the community is mature and happy once more, then those bacterial cells go to sleep again. How amazing, how clever. What we know is you cannot kill bacteria when they're asleep. Antibiotics, antimicrobial dressings only kill these bugs when they're trying to reproduce. So we need these sleeping cells to be awake and active and trying to reproduce in order to kill them. There is an important piece of information that we have learned. What happens is you can have your community well established, nice and mature, sleeping cells at the bottom, but the layers at the top keep shedding off from time to time, which is what they call planktonic bacteria. And the thing is, when you and I do most of the wound swabs that we do, most of the time we are picking up the planktonic bits that have fallen off the top of the biofilm. So whenever we do a wound swab, we will certainly get a report. There will certainly have been bugs that are growing, and we will probably say, that's Bute, and we can now give some Keflex for that. And so what happens is, for the length of time that person's on their Keflex, they're killing off all of the bits of plankton that fall off the biofilm, and things seem to improve for a while that they're on the antibiotics. And then when their Keflex stops, within a few days of that, the wound is starting to get moist again, red again, painful again, and it's getting bigger again. Or more slough is developing again. And it's because all we've done is we've got the bacteria on top, but we never found out what were the cells underneath that we really needed to kill. So before I finish with you in this presentation, I'm going to describe for you a swab method called the Levine method, which is the way of taking a wound swab so that you are more than likely going to get those sleeping cells and find out who they are and what they're doing and start to kill them off. So we'll talk about that soon. This slide's really to remind me to tell you, and it's a fairly busy slide, but biofilms keep wounds perpetually inflamed. And we know now that there is a sequence of steps that a wound has to get through in order for a wound to heal. It has to get through the blood clot. It has to go through a period of inflammation to have our immune system response. It then has to go through a period of proliferation to make brand new tissue. And when new tissue is made, it then has to form a scar. Biofilms tend to stop wounds healing at the point that inflammation is prolonged and goes beyond the normal boundaries of our immune system response, and things stay at a perpetually inflamed state. And when that happens, that then means that surrounding healthy tissue is susceptible and likely to also start to break down, which is why when we see inflamed wounds, particularly those associated with infection, we are seeing tissue damage becoming deeper and bigger and more extensive because inflammation has been prolonged and aggressive. This is the dear man that my wife's presently looking after, and there is with that malignant squamous cell carcinoma sitting right where his ear used to be. So this wound now will be one of the ones that Matt was talking about, where this will ultimately erode. It will go through the jugular vein, more than likely, and he will bleed out. It's a hell of a discussion to have with a patient, to say this is what's going to happen and this is what we're going to do. But it is one that in this situation has to be had. He has a wound which will not heal. It will not remain contained. It is palliative. It will progressively and is breaking down. So that sets the scene as to where we categorise him, and then have to decide, well, what are our priorities for this? And for him, his two goals are to manage smell, which we'll talk about later, and to manage the volume of discharge. And Kate has done that with him, and as we said earlier, did it well enough that he could, with his family, get out to a cafe in public and celebrate his birthday. Brilliant. But what is slough? Because we tend to see slough a fair bit, and usually where there is infection. Slough is, they think, related to a biofilm. Slough is a combination of dead tissue, exudate, bacteria and protein. It tends to be moist, it tends to be stringy, it tends to have some attachment to the wound. It may, at times, be something you can readily remove. But yellow is a bugger of a colour in wounds. Ferrari red is wonderful. It's granulation tissue, it's healing tissue, we love it, like we'd love a Ferrari. The purple pink of brand new skin is awesome. We can see the wound closing. Black and brown we can see as being dead tissue and eschar, and we know that's got to be removed. But yellow is awkward, because yellow can be tendon, yellow can be bone, yellow can be slough, yellow can also be a tough glue called fibrin, which lies on what can even be a healing wound. And the more you scrub it and try to remove this fibrin-y glue, the more you make the wound bleed or traumatise it, and even if you did remove it, it's back within 24 hours anyway. Sometimes it is hard to know, are you dealing with fibrin-y glue or slough, and they can certainly coexist. So these are the situations where you then have to say, okay, well, good wound cleansing, gentle wound debridement, any slough that you can get rid of, you will, and any fibrin and glue that remains with any residual slough, then it does. So you go within the limitations of what that wound presents to you. But we know that normally, even a healing wound would be producing slough, but yet there are cells within your body, including your white blood cells, which break it down as fast as you are producing slough. So a healing wound, the acute wound, the person who's fallen off their skateboard, the donor site wound, your skin laceration, all of those wounds actually produce slough, but you're removing it almost as quickly as you make it. The chronic wound no longer has that balance. And one of the reasons we think that the chronic wound continues to produce slough somewhat unchecked is because there is a biofilm present, and the biofilm leads on to perpetual inflammation and the generation of slough. So if you are seeing a chronic non-healing wound and that wound has slough in it, it is a fair thing to then expect that there is probably a biofilm associated with that wound. Randy Walcott agreed with our dear friend Liel Adam by talking about debridement. He found that if you can break into the biofilm, if you can get through the tough outer cover and you could disrupt that biofilm, it means that that biofilm is broken into, it has to now try and remake itself. That is great. In the effort of trying to remake itself, these cells that went asleep are now awake, and they now can be destroyed. So the way of dealing with biofilms is that where possible, you either cleanse the wound reasonably aggressively or you try and debride it. And what he says here is that biofilms will remake themselves, and you've got around about often a 3-day window. So after debriding a wound, the next 3 days are your best opportunity to really try and kill off all of the bugs in that biofilm. So that's when you'd be using your antimicrobial solutions and your antimicrobial dressings, like your silvers, your iodines, your polyhexanides, and so on. And then the other thing Randy is saying is we need to be debriding regularly, because if your biofilm's remaking itself in 3 days, then it's feasible to then think that maybe 2 or 3 times a week, maybe even every time you're doing a dressing change, we should be debriding the wound, rendering those senescent bacteria susceptible, and then apply your antimicrobial solutions. This helps explain why when we use iodine and silver dressings and polyhexanide dressings and so forth, that sometimes we get a bit disappointed about the results for the expense of what we paid for these products, and we're thinking we're not really getting the advance that we hoped we would. And the reason for that is that if slough is still present on a wound surface, you may not have had the opportunity to disrupt your biofilm. Therefore, these cells based at the bottom of that biofilm have not been rendered active, and therefore they're not susceptible to your silver or to your iodine or to your polyhexanide. So in order to get the most out of your bug-killing dressings, we really need to be cleansing and debriding wounds every time we come to be using these particular dressings. And that's something that a lot of us have not necessarily been taught to do. But that is something we should be doing to get best benefit for our patient and for the cost of what our products have been to us. There are a number of debridement options. For you and I, most of the time we have access to autolytic, mechanical and osmotic forms of debridement. We'll go through them in a minute. I've had the opportunity and the privilege of working with a friend of mine who does ultrasonic debridement for her patients' wounds. That is particularly efficient, gets excellent results. It's not cheap, it's not always something that's reimbursable, but it is a technology which I think we will see more of, and it is something that trained nurses are able to do really well. Negative pressure wound therapy. It's really worthwhile talking to the trade here who've brought their negative pressure wound therapy options with them, because we believe that the actual method of applying negative pressure to a wound can help in a debridement phase, and also some of these negative pressure devices allow you to use antimicrobial solutions with them, which helps you then reduce biofilm communities. So there is growing interest in some of the debridement qualities of negative pressure. I want to spend a moment before going back to the top 3 about talking about larval therapy, which is of course maggots. Now, dear Matt, he and I didn't coordinate it, but I'm so glad he brought the picture of that guy's head, because it was infested with maggots. Now, the thing about maggots is they are very good at getting rid of dead tissue, and they actually are very good at disrupting biofilms. Not that I'm suggesting to you the next time you've got a sloughy wound, stick your resident out in the sun and hope he gets fly blown. That's probably not really a reasonable course of action, because the maggots that are useful happen to be manufactured in a laboratory at Westmead Hospital in the Department of Entomology, and they are brought to us by the green bottle fly maggot. Why that particular maggot? That maggot tends to eat dead tissue, and then when it gets to a healthy blood supply, it detaches itself from the wound and rolls away. The maggots you saw on Matt's patient's head, and that I've seen in fly-blown wounds, many maggots do not differentiate between the types of tissue that it's ingesting. And it is possible for maggots, once they've dealt with the slough, to keep on burrowing into planes of fat and other healthy and viable tissue. So you do need to choose your maggot carefully. Also, there are 2 ways of using maggots. Maggots politely these days are available in something that looks like a tea bag. And one of the things about maggots that debrides wounds are its sputum and its vomit. It's the enzymes from the gut of the maggot is what's useful. The trouble is about putting them in a tea bag is they're all contained, which is lovely. You and the resident doesn't see them, which is also lovely. But it means that one of the debriding actions of maggots is the use of their jaws and their teeth. You don't have that action when they're in the tea bag. So maggots in the tea bag might help you produce fluid, which may be useful against biofilms, but it is less efficient at getting rid of slough. Now, if you're particularly brave and you'd like to go free range, then you can physically take maggots out of a bottle, count them into a wound, and seal off a wound and protect that wound. And then within 2 days or so, then count them all back in. And curse the little bugger who've just happened to get away and you've got no idea where he is. All but one is now in the bottle. That happens from time to time. But the free range maggots will give you better physical debridement. Now in Australia we do not tend to use a lot of maggot therapy. It's a bigger deal in Europe and in the US than here. We're a bit restricted by access to them. We are certainly restricted by having reimbursement for them. They're not very cheap. And also we're not very well educated or trained in the use of them. In my own practice, it's only a handful of times that I've used maggots, and a number of those times people arrived with them already in situ, and it was a matter of getting them out because they probably weren't the maggots we were after in the first place. So it's never good after a bowl of rice bubbles to be searching for maggots. I wouldn't recommend doing it too often. So maybe have the maggot release and collect them all and then have breakfast afterwards would be a better idea. The autolytic debridement is something which is an interesting conundrum because autolytic debridement relies upon the white blood cells that are present in the wound fluid to eat away at devitalised tissue and slough. And that can work okay. It's a slow and a somewhat inefficient process, and it tends to work best where dressings are occlusive or semi-occlusive. But it means, though, that because the dressings are occlusive or semi-occlusive, the wounds can't be too wet, because otherwise there's too much maceration that builds up around the edges of these wounds. And it means you can't use occlusive dressings when you actually have infected wounds. So using autolytic debridement is really a process which is hard to do when you've got slough and potential wound infection, which is why now mechanical and osmotic options are possibly better. The osmotic options are things like honey. Honey, if we get a chance, if I don't rave on for too long, if we can talk a bit about honey, we will, but there are multiple modes in which honey works to kill bugs. And the osmotic action of being able to draw fluid out of the bacterial cell so that the bacteria implode on themselves is one way of doing it. Another way of doing it is using hypertonic saline, 20% sodium chloride, in either a gel or a gauze pad. And that is a very cheap form of antimicrobial agent and one we underutilise. But it is a good way of being able to kill bugs on a wound and also have some debridement of a wound. Things like Mesalt, Curasalt, Hypergel is the gel equivalent. These are good quality products. You just have to be a little bit aware that on granulation tissue it will be painful. We do have to be aware to protect the surrounding skin because it can traumatise the surrounding skin, so skin barrier protection is useful. The forms of mechanical debridement, well, historically I went through the time when plastic surgeons and I did my training within a plastics environment, and for many years we thought the saline wet to dry pad was the ant's pants. And in every 2 or 4 hours you'd put on a fresh saline soaked gauze, you'd let it dry out, you'd come in and you'd reef it off the patient and you'd take off slough and maybe some viable tissue as well. Patient would thank you most graciously for how much you just hurt them. And, it was one of those things where people were usually on fairly high levels of analgesia. It was fairly barbaric now that I look back on it compared to what we've got available now. But I can say wet to dry dressings do work really well as a debridement device. But these days you've got things like tender wet. I don't think Hartmann are here today, but it is a pad that you would put onto a wound which can leave on for even up to as much as 24 hours. And what that pad does is slowly release an isotonic solution onto the wound which starts to break up slough, and then that slough is then absorbed into the pad. These things are great. They're reasonably cheap compared to some of your other dressing items, and if you're only changing it once every 24 hours, it's a pretty decent way of getting a cleaner wound. So tender wet, in the UK there's a newer version of it called Hydro Clean, which I think we'll probably see in Australia in the next 12 months or so. But it's the monofilament pad, which I mentioned earlier is Debris Soft, and then the newer American device called Ulcer Cleaning System, which will change our practice so that every time we come to clean a wound, we probably should be using Prontazan or saline and one of these kind of devices. And then if we are using these to clean a wound, then what we are doing is disrupting a biofilm so that we're getting value out of our antimicrobial from that point onwards. So watch this space. Debris Soft is here now. Ulcer Cleaning System will come at some point, but these will soon need to become regular parts of our practice. And that's what Debris Soft looks like. The number for Century is there if you need to give them a ring. So tell you what, I'm going to have a 10-second drink, and if you wanted to write it down, go ahead. Right, thanks for that. Vicky Allen, who works with Century, sent me her apologies that she couldn't get here today, so I was pleased to show you that. This is another example of how good it is to have our friends in the trade, because I don't see them as there to sell us stuff necessarily. They do that, of course they do that. But when you've got their expertise with products that help us intervene with real situations for our patients, the knowledge and expertise that our friends in the trade have really means that they can be some of the best clinical partners that you and I could ask for. These are a range of solutions that can be used on a wound when you've just cleaned it to help break down a biofilm. Are you all familiar with something called Prontazan? The B. Braun folks have that here. And that's polyhexanide is Prontazan. And it is the solution out of all of those up here that we are most familiar with. However, all 5 of those things are on the worldwide market. The newest one is one called hypochlorous acid, which I hope that in the near future we get to see brought to Australia. Out of all of those, it's probably the most useful at breaking down a biofilm. Sounds like Mr. Whippy. There is your list of antimicrobial dressings. There's only one there I need to explain to you a bit more, and that is DAC. Have you come across a dressing called Sorbact? If you haven't, it's worthwhile just being a little bit of aware of. They've got a good YouTube, a pretty decent website, but it's a fatty acid which, believe it or not, comes from spider webs, or is very similar to the fatty acid in a spider web. I remember reading an article once when it talked about the kind of dressings that were being used in England back in the 15 and 1600s. And one of the favourites was stopping wounds from bleeding and helping wounds heal by wrapping them in spider webs. I had no idea why that was going to be beneficial until more recent years, where we know that the fatty acid that would have been in those spider webs is actually now in a dressing for you and I to use. It doesn't kill bugs. All of those other things there kill bugs. What it does is it uses this thing called hydrophobicity. Now, bacteria, they actually have a wall which expels water, pushes water away from it, which isn't that fascinating, that they love moist environments, but yet the wall of the bacteria will push water away. It's what they call hydrophobic. The fatty acid also pushes water away. Now, if you bring two surfaces together that are trying to push water away, and those two surfaces touch, they stick to each other. So with this dressing, every time you take it off, you are taking bacteria off the wound surface. So this approach relies on every dressing change, bacteria are being reduced on the wound surface. It's a very physical entity, a physical removal. Now, this is a bit of a personal story which I will briefly tell you and then move on to the conclusion. Because I've always been a bit fascinating having read about this principle of hydrophobicity. Because our skin is like that. You look at our outer skin cells, our epidermis, and one of the things that the keratinized layer does on our outer skin is to push water away. It's one of the things that stops you becoming macerated whenever you have a shower or a bath and so on. So that's there all over our body. I have a 25-year-old son and his fiancée living at home with us. They're going to get married in December this year. And being deeply in love and affectionate and all of that, I've realised that the act of smooching is very much a principle of hydrophobic action in play. So that whenever the lips separate, you tend to get that smacking noise as these layers of tissue which had briefly stuck to themselves now separate. So if you're ever at a loss to recall the principle of hydrophobicity, just give someone a bit of a pashing off and you'll discover it soon enough. And there it is, the principle of hydrophobicity is right there before you. I knew you'd need to know that, so there we are. Okay, now the other thing is, and this might be this slide and then the Levine slide we'll talk about. If we're going to be using antimicrobial agents, solutions, dressings on a wound, a rule of thumb suggests that if we're going to make any difference to the wound, and we've cleansed the wound well, we've broken the biofilm, we've applied these agents, if it's the biofilm that's responsible for the wound to be stalled, then within 2 or 3 weeks of debriding the wound, cleaning the wound, using the antimicrobial agent, we should see progress. If you have cleaned the wound well, you've used these anti-bug cleansing agents and these anti-bug dressings, and you are now 3 weeks down the track after continuous use of all these things, the question now to ask is our diagnosis correct? We do not want to be using silver dressings for 2 months and 3 months, spending huge amounts of money and thinking this wound has got nowhere. Just because a wound has slough, just because a swab showed that it was bacteria, may not always mean that the bacteria nor the biofilm are necessarily the reason for the wound to become chronic. But in all chronic wounds, biofilms may well play a role, and at least you're a bit now familiar with what the biofilm is. The last bit to finish on, before we go to the next speaker, thank God they say, let's have the next one, is there is meant to be a wound and a cotton tib for a bacterial culture. The Levine method is what is now recommended for when you and I come to swab a wound. The idea is you do not come near the wound with your swab until that wound has been well cleaned. You do not want the exudate. You do not want the stuff that is on top of the wound. What you want is to get down to what is underneath. This means that we need to be scrubbing the wound, cleaning the wound, irrigating the wound, whatever you can do to get to the cleanest part of the wound that you can do it. Then you find that part of the wound which is either at the deepest point or which is at the wettest point. And now I want you to look at your thumbnails, because the thumbnail is the surface area that you will now take your swab from. Get your cotton tip, and I usually say to people, get your cotton tip, put it back into the tube and get some of the culture media from the tube onto the cotton tip so that it is lubricated. Because what you want to do now is you get your cotton tip, you put it onto the wound perpendicularly, and you push hard and you rotate it. And you may do that for between 15 to 20 seconds, which is a long time to do it. What you're really after is to have enough pressure and enough rotation that you can get little bits of cellular material into the swab tip. That's where you'll get some of these senescent cells. That's where you'll get a far better idea of what it is that you actually need to kill. Well done. I haven't heard any snoring yet. You managed to get through that bit.